right? And we need to be able to talk about them in the proper way. Like, oh, this looks darker, this looks lighter, right? So, we're going to be using some specific verbs. So, from your homework, what does it mean for something to be radiopaque?
Light.
Okay, sorry, Dan.
But that means it's
Okay, all right, Shaheen.
It's dense and it's thick and it doesn't let things go through.
Dense, thick doesn't let things go through.
it appears light or white.
Appears light or white. Very good. So those two definitions together are perfect. It's something thick, it blocks X-rays, and so because it's blocking the X-rays, it looks white or it looks bright on the image. So what about something that is radiolucent?
Dark.
Dark.
Okay.
It appears like near black or black on the X-ray.
It's near black or black on the X-ray. Veronica.
See through, like dark.
You can see through, dark. All right. Very good. So it lets X-rays through. The X-rays reach the detector and it darkens the detector, so it looks black or it looks dark. Great. So if we take a look here, we've got A, B, C, D, right? Look at the little boxes here. Which box looks the most radiopaque?
C.
D. So this left lung here?
Yeah. Radio?
You said radiopaque?
Radiopaque.
C.
C. Right. C looks radiopaque, right? Really bright means that X-rays have been blocked here. Okay. Why? Because what is this covering? Spine. Bone, right? Bone is very radio-dense. It absorbs X-rays, so it keeps things from going through. Okay, which one looks most radiolucent?
D.
D, right? It's all air. It's the side of the patient, so X-rays just pass through the air, hit the detector. Nothing got absorbed. It all reaches it, turns it nice and black. All right, so taking a look here. The body can have many different types of things in it, right? Air, fat, water, bone, metal. The more dense something is, okay, or the more radio-dense something is, the more it absorbs X-rays, and the more radiopaque it is. Right? So radio-dense items are radiopaque. So the non-radio-dense items are going to be radiolucent. Right? So as they get more dense, it becomes whiter. As they get less dense, it becomes darker. So what is the question? Sort the following from most to least radiopaque. So which one here is most radiopaque?
Metal.
Metal, great. So metal, bone, water, fat, and then least radiopaque is air.
I did the opposite.
Okay, now we know. So when we talk about pathologies, then we can say, oh, this pathology is going to be more radiodense, right? You know, if I say the pathology is radiodense, how do you picture the X-ray looking?
Dark.
White.
It's more whitish.
Why? Because you want that light go through, it should go through.
Good. So if I say the pathology makes things more radiodense, then you expect the image to look whiter, to look brighter, right? If I say that the image makes things more radiolucent, what do you expect it to look?
Dark.
Darker, black. Very good. Right, so we will see pathologies that affect the lungs. It makes the lungs look more radiopaque. It makes the lung look more radiolucent. Right? And so it's important to be able to predict how that actually looks on the image. So, as you may have noticed, we have quite a few pathologies for this chapter. Aspiration, atelectasis, bronchostasis, okay. I'm not going to read all these. You've already seen them in your homework. Okay?
So this is for the pathology. This is chapter 2 or chapter?
Oh,
This is
I'm sorry.
chapter
This is
3.
chapter 3. Chapter 3. Thank you. Thank you. This is chapter 3.
Good catch, Moses.
Good catch. This was chapter 2 in the old book, but this is now chapter 3.
As long as it's the same
as
stuff,
in
sir.
Von Traeger's?
Well,
Yes.
it is, but just the chapter.
I mean, it's not like pathology changes between textbooks.
Neither
Tuberculosis
does
is
No, meaning that
one
maybe-
way in Bontrager's and a different way in Nero's,
Yeah,
right?
maybe
You never
If they are different, someone's done something terribly wrong. And I'm putting money on the
Bontrager's?
big B. Okay. So, we are gonna have a chance to go over all these pathologies. What sort of things are we gonna be looking for? Well, let me give you an example. We're gonna be looking at what kind of x-rays will help us demonstrate that pathology. We're gonna take a look at, do we need to make any changes to our exposure factors, to the energies of our x-rays? And then we're gonna talk about what the pathology is and any information about it that might be important and how it looks on an x-ray. Now remember, I am not expecting you to diagnose patients. I'm not going to give you a picture of a chest x-ray and ask you, all right, what does this patient have? However, I may point to specific things and be like, okay, what is this here? Right? And you'll see what I mean when we go a little bit further. Right? Or I may ask you questions like, okay, what kind of x-ray, what kind of x-rays would you use for this kind of pathology? Actually, you know what? Let me take my earlier statement back. If it's something super obvious, I will ask you what it is.
Like atelectasis or something like that?
That one's iffy. So chest stuff is kind of iffy, but when we get to fractures, fractures are a lot more straightforward. So it's like, all right, here's a picture of a fracture. If you know what bone this is, if you know which direction the fracture is breaking in, you have a pretty good idea of what the name of this fracture is. That is going to fall under pathology. All right, so let's talk about aspiration. What is aspiration? Right, so usually foreign body enters the airway, gets stuck inside, right? Something in the respiratory system that does not belong. Most often happens with kids, right? Kids love swallowing things, especially things that should not be swallowed. Okay. And then this object will usually block up some or all of the airway. So, as far as x-rays go, we do chest x-rays and we do upper airway x-rays, right? Makes sense, right? Our soft tissue necks. Okay. Because we are primarily looking at soft tissue, we're not concerned with the bone, our energies are going to be targeted towards the soft tissue. We're using soft tissue techniques. So usually soft tissue techniques are going to be lower than bony techniques. Okay. Now, one more thing to note. Most foreign objects are radiolucent and are rarely directly demonstrated. So if someone swallows a peanut and starts choking on it, right, and it ends up inside their left bronchi, you're not going to take an x-ray and see a giant peanut sitting right here. Usually, something like that is going to be very hard to see, okay? Because, you know, peanuts are made of similar material as the body. It looks very similar, or it lets x-rays through. So it's very, very hard to see these structures a lot of times. The exception would probably be like a fishbone. Fishbone is usually one of the few things you can see nice and clearly. So, what do we do instead? We look for other clues that there could be something going on. So one of the things that happens with aspiration is thing gets stuck in the bronchi, patient breathes in, air goes past the object. Patient breathes out, air gets stuck. So air comes in, but it does not go out. And so now there is a buildup of air in one lung. Now, is air radio-opaque or radio-dense? Or sorry, I said radio-opaque or radio-lucid?
There was no good answer.
There's no good answer. That's true. Okay, so Radiodense or radiolucent?
Radiolucent.
Okay, radiolucent. So if you have a buildup of air in the lung, then how do you think the lung will look? What color would the lung turn? It would turn more black because air is radiolucent. So if you take a look at this X-ray right here, you look at the right lung, you look at the left lung. How does this lung appear compared to this one?
They have more air.
Right, so this right lung here looks more radiolucent than the left lung, correct? So which lung do you, or which side of the bronchi do you think this foreign body is in?
Right side.
The right side, very good. So there's an obstruction somewhere here on the right side, which is trapping air inside the lung. Okay. Right lung appears less radiodense due to obstruction trapping air.
So you don't necessarily have to even see the obstruction. You can just basically kind of tell that it most likely is one because it's more black than the other one.
Correct.
Okay.
So sometimes you can see the obstruction, most times you won't be able to, but there are these other signs you can look for. Okay, next up, atelectasis. What is atelectasis? Charles. All right, Charles, go ahead.
Collapse of the lung.
All right, collapse of the lung, good. So either a full collapse or a partial collapse of the lung. Doesn't have to be the entire lung, could just be one of the lobes of the lung. By the way, how many lobes of the lungs are there?
Total?
Okay, total 5, very good. So which one has the 3 lobes?
Right.
Right side, which one has 2?
Left.
Left side, very good. So, with atelectasis, we are going to be doing your chest x-rays once again. Okay. With atelectasis, how does this appear? Well, we are losing lung volume. So we're going to have less air in the thoracic region, right? Because the lung is getting smaller. So we're losing a radiolucent region, right? We're losing this area of low radio density, which means how will the image look overall? If there's less lung, how will the image start looking?
More
White.
white.
Right, it's going to start looking more white, right? It's going to look more radiodense. So to compensate for the fact that it's looking more white, we may need to increase our technique, increase our energies, so that we can shoot more X-rays through and make it look less white, make it look darker again. Does that make sense?
Yes.
Okay. Atelectasis is a condition rather than a disease, so it's a condition, or it's like a symptom of disease. Different things can cause atelectasis. Yes, Jay?
Would a patient suffering from this condition not be able to hold their breath as long? So you have to like sort of make adjustments while you're taking these x-rays?
That's possible. That is possible. So another thing is that because we are losing lung volume, the cost-effective angles here, sometimes they may not look as sharp, right? Instead of this nice point, it may look more rounded, right? It may start to disappear. It may look more flat rather than sharply angled, like a triangle. Okay.
Radiodense is light.
Radiodense looks white, looks light. So if you take a look at the lung here, right? Okay, I put the answer at the top. But if you look at the lung, do you see an area of this lung that looks lighter, looks more bright than the other parts of the lung?
Yes.
Which part?
Upper right?
Good. Upper right part of this lung, right here.
And also the
Here? So what is this right here?
Heart shadow.
Right, that's heart shadow, so be careful.
It took me a little bit.
Yeah.
I just
So
thought it
that's
was
the
a
heart
small
absorbing
piece
X-rays, that's why it looks more light.
So the apice of the right lung would not necessarily be where it should because it collapsed, right?
Right, so normally this should be black because the apice of the lung is filled with air.
Right.
It looks white because
pack
it
is when
has
it's black,
collapsed,
when it's
and so
white.
now that's no
Radio
longer air in
translucent
the
is when it's
region.
So
black.
you would finding the APC here, that wouldn't even be like something we need to do for that, because it's kind of hard to estimate where it would fall.
So you still want to demonstrate the region where the apice would be.
Yeah, like would be, but I'm saying like if someone said, all right, now point to where the APC of the right lung is, as opposed to where it would be.
Don't worry about that.
Okay.
It's the more dense the wider it will be.
So as you can see, right, the lung has kind of like shrunk down to this region here. This entire upper lobe is gone. Okay, some other examples. Okay, over here on the left picture, do you see the area of atelectasis?
Yeah, it's on the
left
side.
Right
Okay.
bottom, sir. Where
This
the
picture.
yes, sir. Right bottom.
Here?
Yeah.
Yes, sir.
No, this is abdomen.
Oh.
Here? This thing? This thing?
No.
That's your stomach air bubble, gastric air bubble.
Would it be the up and to your right? No.
That's the
There you
heart.
go, down a little bit. A little bit more to the right. Right there.
It's left and
No,
right.
this is
Is that liver?
liver's liver's like right here.
Okay.
So
Both lungs?
it is actually
more dense.
this right here.
Two
Those two things right here. Why? Because if you think about the lung, right? Lobe, lobe, it's shrunk, the lobe has shrunk here, right? So you start seeing this separation, right?
Which
So you see
lobe
this
shrunk?
density.
Which lobe?
Both sides are showing it, right? But, right, you've got like your lobe,
Yes.
right? Your lobe is slightly smaller now, so now you've got this area of density where normally you would expect.
Oh, so that's
air.
like the partial collapse as opposed. Okay.
Correct, partial collapse of one of those lobes, the lower lobes. Okay. So now that you see what it looks like here, what about on the right side? Okay, where's right there? Okay, so let me put my finger. All right, which way am I going?
Down.
Down.
Right.
Right.
Going down. Yeah.
Very good. Right, this is the collapse of the right middle lobe. So that is how atelectasis can look on an X-ray. Are we good at this?
Oh, don't change it. Hold on.
You
Sorry.
have the power.
I know, but I want a picture. I like the
Easy
look.
access.
Yeah.
right.
All right. Thank you.
Okay, next up, bronchiectasis. So this is an irreversible widening of the bronchi or the bronchioles. Right, what are bronchi and bronchioles again? Bronchi and bronchioles?
Branches.
No, man.
Okay, Jay, go ahead. I heard branches.
Thank you.
Branches of what? I
The
see
lungs.
branches of, okay, of the lungs. Right, so not those branches.
No.
So yes, branches of the lung, right, coming off the trachea.
So the branches of the trachea, right? So not the
No,
lungs.
none of the, it's not branches of the trachea.
That's
It's
right.
it's-
No.
Always answer.
Oh,
That's my
no.
question to you. Why did you say branches of the lungs?
it's-
So with the trachea branches, so it becomes the
Okay,
bronchi.
all right, that's true. The trachea branches and then into bronchi, and the bronchi branch into bronchioles. Right,
Oh, yeah.
as long as we understand what we're talking about, okay, it doesn't need to be that specific. All right, but here we have this widening. Why did they get widened? Because they got inflamed, right? There was inflammation, and then when it got inflamed, right, it damaged the walls. So after the inflammation's over, the walls aren't able to go back to that original small size. Okay. In addition, there might be pus that gathers there in those regions. So now the bronchioles have expanded and they've been filled with pus, filled with fluid. Fluid, how does that compare in density to air?
It's more radio
Less.
dense.
Radio.
More radio dense.
Okay, fluid, water is more radio dense than air. So, bronchioles normally have air in them. Now they are fluid. So how do they appear?
Right.
They appear whiter, right? They appear brighter. Okay. So, we take a look over here, right? So we can, so do we see these lung markings here? These lung markings are much sharper, much more bright compared to a normal X-ray. Right? Let's just go back to something like this, right? You look at like these lung markings. You look at something like this. Do you see how they're much more pronounced, much sharper looking? Right? So bronchiectasis, right? That fluid buildup inside the bronchi and bronchioles. Okay, bronchitis. What is bronchitis?
Inflammation of bronchioles.
Inflammation. How do we know that it's
Itis.
inflammation? Itis. Very good. So inflammation of the bronchioles, right? Bronchi. So, yes.
Can you go back just a little bit? I missed over.
During the test, are you gonna ask?
Just a reminder, you all have the PowerPoints. If you want, you can pull up the PowerPoints right now and follow along.
Okay, let me do that.
You could, yes. John.
During like an exam, are you gonna ask like what view are you gonna take for bronchitis or?
Yes, I will ask about views. So, for example, I could ask you which of these views would be best suited for aspiration, right? And it could be like, all right, well, would you do an AP soft tissue neck, lateral soft tissue neck, AP abdomen, or decubitus abdomen? And which one would be best? Lateral soft tissue neck would be best for aspiration, right? So yes, I can ask questions like that. All right, bronchitis, inflammation of the bronchi. Okay, so excessive mucus secreted into the bronchi, irritates it, inflames it. It can be acute, right? Happens once and then goes away. It can be chronic, long-term, happens over and over and over again. Okay, what can cause this? Viruses, bacteria, or smoke. Because remember, why do we secrete mucus? Mucus is there to help get rid of foreign particles, right? Trap those particles, expel it from the respiratory system. So if there's viruses, bacteria, if you smoke a lot, right? All that irritates the bronchi, secretes mucus, tries to get rid of those particles. So this does not show up very well on X-ray. Okay, this does not show up very well on X-ray. But if it's a very severe case of bronchitis, then you might be able to see inflation or thickening of the bronchial walls. But normally, you're not really going to see much different compared to a normal X-ray. Make sense?
Mm-hmm.
So that's why I don't even have a picture up here for you, because it's hard to find a picture that can properly demonstrate this.
How do you, if it's hard to probably demonstrate it, how can you, I guess, like, how could you find out, I guess? I don't know.
That's a good question. Maybe CT, I'm not sure. Seemed kind of overkill.
Yeah.
Or maybe just a physical exam would be able to see something.
Wouldn't they be able to hear it with like a stethoscope?
Perhaps. Right? Once again, I'm not a doctor. I'm not able to diagnose bronchitis. That would be something to do more research on. Okay? I do not know the answer offhand. Okay, COPD. This one is very common. What does COPD stand for,
Chronic.
Samantha?
Chronic obstructive pulmonary disease.
All right, great, thank you. So, once again, this is going to be just done with regular chest x-rays, or routine PA and lateral. So, persistent obstruction of the airways makes it difficult to empty the lungs. Right? Very similar to aspiration, but where aspiration is some outside object that gets stuck, here is just the body itself having a condition where it just has difficulty emptying the lungs. Okay. So what can cause COPD? Most common root causes are smoking and asthma. Right? So COPD is very commonly seen in smokers.
Chronic.
By the way, if you take a look at the lungs here, right? and just kind of like take a look straight down the middle of these lungs. How easy is it to see the ribs? Really hard, right? Why?
Not at all.
What? Well, what's here? It's all what?
Air.
Right, all that air, right? It turned black, right? It made the lungs more radiolucent. So it's just, you can't really see any details in here because of all that air.
Mm-hmm. The tissue isn't there. Yeah.
Okay. Cystic fibrosis. Anyone know anyone with cystic fibrosis?
That was in that movie 5 Feet Apart.
Yeah.
You do, Veronica? Your mom has it. Oh, wow. Okay. So, cystic fibrosis is an inherited disease. It is genetic. So, you got it yourself. You might want to get. Have you done any like genetic testing or anything?
I'm sorry?
Have you done any like genetic testing to
I
see?
haven't.
You haven't?
She was just diagnosed. She always had issues, and they just diagnosed her a few years ago.
Okay, I see. So so she's always had issues. That makes
But
a
her
lot of
mom
sense.
had issues too, like respiratory.
But you're fine.
Yeah, I haven't had any. But my daughter has asthma, so.
Okay.
She's a carrier.
Well, cystic fibrosis, once again, affects the lungs, so we are doing PA and lateral chest x-ray. This causes the secretion of thick, sticky mucus. Right? So it's no longer as liquid, it's no longer as fluid as normal mucus. And so this clogs up the bronchi, it clogs up the bronchioles. Right? So once again, if we take a look here, right, how does the lung appear right here?
Whitish.
Very white, right? Is it an even white?
No.
No. It's spotty, right? Why? Because these are all of those vessels inside the lungs that are all being clogged up by that mucus. Okay. So, as you can see, this does show up with increased radial density, right? It looks more white. And then also, it may show up with lung hyperinflation. The lung looks bigger than normal.
So when it says may need to increase, they're talking about the dose or the time?
Correct. So we may need to increase the energy of our X-rays to punch through all of this extra fluid.
What is that thing?
This thing here?
Uh-huh.
What is this thing?
That's a pacemaker. No, that's a port.
Good. This is a port. This is a port.
For dialysis or?
Well, I mean, I can't say without
Okay.
knowing the patient, but yes, ports can be used for dialysis, for example.
For drainage also?
Uh,
Because got fluid in this thing. Lungs.
Perhaps. Once again, I'm not sure. Yes, Christina.
While I was working at MD Anderson, a lot of patients had porticats because from chemotherapy, their veins were not that great. So to prevent sticking them over and over, they would just get a port where it would be access to draw blood or to give chemo.
But behind the lungs?
No, the port goes to the heart.
Right. So even though this is at the lungs, if you look very carefully, you see this line here. So this tube actually goes in and it enters one of the vessels, one of the blood vessels. It's not actually going into the heart or into the lungs. And if you are on portables, you may end up doing chest X-rays to check the locations of ports when they get placed, or breathing tubes, or gastric tubes, or all sorts of things. All right, dyspnea. What does dyspnea mean based just on our medical terminology?
Breath.
Shortness of breath. Okay. Well, what is dys?
I think short.
Difficulty.
Win. What is dys? D-Y-S. It's another word that starts with D.
Diagnosis.
No. Difficulty.
Difficult.
Defecate.
It's not
Oh my
defecating.
God.
That's the wrong D word.
Okay, difficult. Right, this is difficult, right? Difficulty. What about dyspnea?
Breathing.
Breathing, right? So
That's when-
dyspnea, difficulty
He was asking
breathing.
when.
Oh, I thought you.
What about apnea?
Sleeping.
What, right?
Sleeping.
Sleep apnea. What is apnea? What is A?
Difficult breathing during the sleep. Or?
A?
A. What is the
The
prefix
lack
A
or
mean?
missing or something.
Right. A is without, right? Lacking, not. So apnea, right? Without breathing, lack of breathing. Sleep apnea, person stops breathing while they're sleeping, right? Then the body realizes, forces them to start breathing again, right? Right? So, right? So they have, and usually when that happens, it forces them to wake up, right? So oftentimes people with sleep apnea have a very poor sleep experience. Okay, but dyspnea, difficulty breathing. So yes, shortness of breath. Okay, this covers a variety of things, right? This isn't a specific disease. This is a condition that covers a variety of things. So it can be caused by restrictive or obstructive defects. It can be caused, right? Here we can take a look. Once again, fluid inside those bronchi or bronchioles makes it difficult to breathe. So radiographs and other procedures are done to make a diagnosis, to figure out exactly what is causing the dyspnea. Oh, actually, this one is not due to foreign body aspiration. I'm sorry, that was an old picture. Take this out.
So that patient had artifacts and leads, or I see a key, I see a lead. What's that in the middle?
Yes, this picture here. So, a key, right? Shirt pocket. Over here, we've got 1, 2, and then somewhere down here, we've got the 3rd EKG lead.
And then bottom right as well.
Okay, here, yep. 4th, 5th EKG lead. This is a 5-lead EKG.
Oh, so that is a lead that's in the middle?
Correct, that is a lead in the middle.
Why does it look different? Oh, it's still attached, isn't it?
Correct, so you can see the wires still attached to it. These do not have the wires attached to the leads up top. So, ideally you would not have this in your picture, but sometimes you can't avoid it because they need to keep monitoring the patient. Oh gosh, okay, I'm over time. All right. We need to go ahead and end class here, so. That's not it. There's
There's 26, right? 26.
Yeah,
You're
right.
over.
We have 26 vocabulary items. All right, so yeah, it's 1:22. So go ahead and end here. Let's take a 15-minute break. So please be back by 1:40, and we will start PRE1.
Oh, I
Okay.
don't like that.
All right, and we'll finish this up